Hello everyone. Today we are going to discuss about status epilepticus. So before starting our discussion, first we will understand what is status epilepticus, what is definition of it. So there are many terminologies like generalized convulsive status epilepticus, non-convulsive status epilepticus, then febrile infection related epilepsy syndrome or new onset status epilepticus. So we'll start with what is generalized convulsive status epilepticus. So any seizure whose motor manifestation continued beyond 5 minutes or seizures by which are repeated at brief interval without interictal recovery of consciousness. That means whenever there is a seizure, it should last at least for 5 minutes to label it as status convulsive status epilepticus, or if they are lasting for the brief period, then patients should not return to their baseline level of consciousness in between. That means if seizure activity lasts for 2 seconds, 3 seconds, 5 seconds, and after stop of or after some brief interval, if the same seizure activity recur and the patient is unconscious, then also we can label it as status epilepticus. So, what is non-convulsive status epilepticus? So, this status epilepticus can present without any visible motor activity, and to label it as a status epilepticus, that seizure activity should last for 10 minutes. Now, while working in ICU, we have seen many neuro patients who are operated for their IC bleed or any intracranial hemorrhage. Suddenly, one day we are finding their BP is high. They are becoming tachycardic, and we are doing every possible thing to control their blood pressure, but the BP is not controlled at all. We are starting with labetalol infusion, nitroprusside, all the possible medication we are starting. Still, we are finding the BP is high only. And so the we should so whenever we are facing this situation, these post operative cases, BP is high, suddenly they are becoming tachycardic, high blood pressure, then always keep the possibility of the non convulsive status epilepticus in mind. Means I have seen two cases. When I was working in ICU, the same. So we did all the possible things to control their blood pressure. Finally, we think this could be the non-convulsive status epilepticus, and we have ordered EEG. So when we have started the anti-epileptic medicine, so at that time we have started locosamide, and the magically BP came down. He was off that patient was off labetalol, and so we should always keep the possibility of this non-convulsive status epilepticus in mind. So what is refractory status epilepticus? So the persistent seizure state despite administration of at least 2 appropriate doses of parenteral medication, including benzodiazepine. Means we have started benzodiazepine, we have started this second line anti-epileptic seizure medication. Still the seizure activity is continued, then it is refractory status epilepticus. Now the new onset refractory status epilepticus is something for which clear etiology cannot be identified within 24 hours of onset, or patient was not having any history of epilepsy in past, then that status epilepticus will be labeled as new onset. Now, what is febrile infection related epilepsy syndrome? So, there should be the febrile illness which are starting between 2 weeks and 24 hours before onset of refractory status epilepticus, with or without fever at the onset of status epilepticus. Now, what is super refractory status epilepticus? So, even if we have started this third line anesthetic anti-seizure medication, that is patient is on the continuous midazolam infusion, propofol infusion, still the seizure activities persist, then that is super refractory status epilepticus. That is the persistent state of status epilepticus at 24 hours, even after starting anesthetic treatment, or if there is a recurrence of seizure after reduction or withdrawal of sedation, then that is labeled as super refractory status. Now, when we know this is refractory, this is status epilepticus, our next job is to find out what is etiology. So etiologies are, it could be the drug reduction, withdrawal of the drug, withdrawal of already already this patient must be on the any anti-seizure medication, and the patient must have stopped that, or any cerebrovascular cause like ischemic stroke, hemorrhagic stroke, subarachnoid stroke, any metabolic disorders, acute CNS infection, then hypoxic ischemic brain injury, or it could be simple alcohol withdrawal, drug overdose, head trauma, brain tumors, or cause may be immunological or cryptogenic. Now about pathophysiology, now why it is happening. So there are two important processes which are responsible for the pathophysiology. So first, that maintains the seizure activity, and it results into the failure of mechanism of underlying seizure termination. That means that some trigger, that some pathology, some cause that is responsible for that seizure activity, and that this underlying mechanism is unable to fail that termination of the seizure. So the second is seizure induced alteration in the neuronal circuit. So that means so that there is a progressive resistance to the anti-seizure medication, particularly benzodiazepine. So there are two receptors. It's one is NMDA receptor and the other is GABA receptor. So NMDA receptor is excitatory and the GABA is inhibitory. Whenever there is imbalance between these two receptor, then that is responsible for the seizure activity and the progression. That means there is an overactivity of this NMDA receptor, which results into the internalization of the calcium, and that leads to the neuronal death. So between this NMDA receptor activation and neuronal death, there are several intermediate steps which are occurring, like generation of the free radicals, accumulation of the calcium, which all are responsible for the status epilepticus related neuronal death. Now, how to tackle this situation? So, anti-seizure. So we'll see how to manage this situation. Now we'll start with anti-seizure medication. So benzodiazepine is the first line treatment. So in benzodiazepine, we can use the IV lorazepam, clonazepam, midazolam. Uh, lorazepam and clonazepam, these are the preferred benzodiazepine because of their longer redistribution half-life compared to other benzodiazepines. So if in emergency, if we are not getting IV access, then we can give intramuscular midazolam. So benzodiazepine should be avoided if the seizure, if clinical seizure has spontaneously stopped due to their sedative and the respiratory depressive effect. So a recent study highlighted that the persistence of seizure active status epilepticus was observed in 70% of generalized clonic status epilepticus at 1 hour after initial treatment, and 58% in non-generalized clonic status epilepticus at 12 hours even after treatment initiation. So when two doses of first line benzodiazepine have failed, then we should go for the second line anti-seizure medication. In second line anti-seizure medication, what all we can use the three drugs like levetiracetam, valproic acid, and fosphenytoin. If you are now which one is more effective? So there is a trial which was conducted regarding this, which was ESET trial. This trial showed all these three medications are equally effective. So we can use, there is a no first line drug in this. So we can use either levetiracetam at 60 mg per kg, valproic acid at 40 mg per kg, and fosphenytoin at 20 mg per kg. So these drugs lead to seizure cessation and consciousness improvement by 60 minutes in approximately half of the patient with same efficacy. So, but what, so we should be aware of this adverse effect of this drug, so that we can make the proper selection. So, the adverse effect of the fosphenytoin is hypotension, bradycardia, and arrhythmia. Then levetiracetam, chronic psychiatric symptoms can occur. Valproic acid, there will be ammonia elevation and encephalopathy. So we can use any of these drugs, but administration of levetiracetam and valproic acid is easier. Phenytoin is usually associated with the cardiac effects, like it can cause arrhythmia and hypotension. So lacosamide can be used as an intravenous preparation, and it is an alternative to this all second line medication. Now the trend trial, which showed demonstrated there is no difference between lacosamide and fosphenytoin. Now, regarding temperature control, there is no rule of therapeutic hypothermia, but we should avoid fever because fever has proconvulsant properties. Now, about focal status epilepticus. So, focal status epilepticus is the seizure that starts focally within the brain, and it is an equally emergency clinical situation, and it is an equally emergent clinical situation. So it happens with the motor onset, but there won't be any loss of consciousness. And to label it as status epilepticus, that motor activity should persist for more than 10 minutes. So how to treat this focal status epilepticus? So for treating focal status epilepticus, first line agent is IV benzodiazepine, followed by second line phenytoin, valproate, levetiracetam, which is same as status epilepticus, but for second line lacosamide can be used. So finally, the sedative drug should be delayed as long as possible in patient with refractory focal status epilepticus. Now about the refractory status epilepticus. The refractory status epilepticus requires invasive ventilation and anesthesia to suppress clinical and electrographic seizure. So the continuous EEG is necessary at this stage to monitor the efficacy of treatment. And there should be early initiation of IV anesthetic and rapid titration to achieve seizure control. So high dose of sedation seems to be associated with lower prevalence of withdrawal seizure after sedation weaning and short duration of mechanical ventilation. Now, the how long once we have started this anesthetic medicine, how long we should keep it is the topic of the debate. But they are saying, but the recent, but many studies, many retrospective studies, they have suggested 35 hours is the best duration to prevent seizure recurrence. But at least we should keep it, we should maintain this therapeutic coma at least for 24 to 48 hours with progressive dose reduction and continuous EEG monitoring. Now, the which one should be used? Should we go for midazolam or should we go for propofol? Is the again not clear, but they can be they both are first line agent, but the choice is always depend upon the disadvantage of it. So, if you are start planning to use midazolam, then it is associated with tachyphylaxis, hypotension, delayed awakening due to long term duration in ICU. If we are planning to use propofol, then it is then we should be aware of the propofol infusion syndrome, which is manifested as hypotension, hypertriglyceridemia, acute kidney injury, and rhabdomyolysis. So whenever we are keeping any patient on propofol infusion for 48 hours, then we should be aware of the patient can go into propofol infusion syndrome. Now, the specific treatment for new onset refractory status epilepticus and febrile illness associated status epilepticus. So, therapies for potential encephalopathy should be urgent to limit the associated mortality. So once we have excluded the infectious cause, we can start with immunosuppressive treatment. So first line immunosuppressive treatment include high dose methylprednisolone at the dose of 20 to 30 mg per kg for 3 to 5 days. We can start with IV immunoglobulin 2 mg per kg over 3 to 5 days, or we can start with plasma exchange. Now we can also go with the second line immunosuppressive therapy in refractory cases like rituximab at the dose of 375 mg weekly for 4 doses, and Kindra 5 mg per kg, and tocilizumab 8 mg per kg. All these second line immunosuppressive treatment are taking care of the inflammatory response which is generated in the form of cytokine storm and the interleukins. Now, the next is superrefractory status epilepticus. So, the management of superrefractory status epilepticus is difficult, and there is no high level of evidence for specific treatment of this rare condition. In all cases, anti-seizure medication, sedation, and specific immunosuppressive treatment should be discussed with the expert team. It should be this is the situation that we have to involve the multidisciplinary approach will always work. The continuous EEG is necessary to assess the seizure control. The continuous EEG is mainly accessible in highly specialized or expert ICU team, suggesting that this patient should be referred to the center for monitoring of epileptic activity. So in super refractory status epilepticus, propofol and midazolam infusion can be combined, and then IV phenobarbital at high doses can be added. So some recent study also suggested that ketamine can be used with this situation and it has 80% efficacy. Again, there is a controversy about the using hypothermia, but yeah, we should avoid the fever and try to keep the low temperature because it has a neuroprotective effect, but it's not proven by the studies. So next line of management is the ketogenic diet, immunosuppressive therapy, neurosurgery, and neurostimulation. Again, there is no evidence to support all this therapy, but we can try. So if I want to summarize the all the treatment of status epilepticus, then we can summarize like this. If we have diagnosed status epilepticus, then we can start with first line IV benzodiazepine like clonazepam, that is 0.015 mg per kg. We can also start lorazepam, that is 0.1 mg per kg, midazolam, that is 0.2 mg per kg. If the seizure is not controlled, then we can start with second line therapy like levetiracetam 60 mg per kg, valproic acid 40 mg per kg, phosphonatoin 20 mg per kg. If the still seizure persists, then we can start with infusion of either midazolam and propofol. Midazolam can be started as infusion of zero point 0.2 to zero point 0.6 mg per kg per hour, or propofol in the dose of 2 to 10 mg per kg per hour. And if still we are not able to control seizure, then we can start the combination of midazolam and propofol, and we can add thiopental in it. So and the other and other we can think and at this point we can think about other therapies like ketamine we can use. We can go for therapeutic hypothermia, ketogenic diet, and if we have exclude this infective cause, then we can go for the second line therapy like tocilizumab, rituximab, and ankara. Thank you, guys.